First, the definition of uric acid. The specific learning outcome, as usual, is that at the end of this lecture, the students should be able to describe some of the common disorders of uric acid metabolism. Uric acid is the product of metabolism of purine nucleic acids. The purines such as adenosine and guanine from the breakdown of ingested nucleic acids or from tissue destruction are converted into uric acid primarily. This is purine metabolic pathway. Phosphoribosyl pyrophosphate, which comes from ribose 5-phosphate pathway, along with glutamine in the presence of PRPP, amylotransferase is converted into the purine nucleotides. These purine nucleotides are further converted into purine bases, which are then broken down into xanthine and uric acid, and then eliminated from the body. These purine bases are again converted into purine nucleotides through HTPRT enzyme, hypoxanthine guanine phosphoribosyl transferase enzyme, and this salvage pathway is responsible for converting these purines back into the RNA and DNA. This is a brief account of this purine metabolic pathway. A more simpler diagram. The bases are converted into urates, which are eliminated through urine or intestines, and excess of urates are deposited in the tissues in the form of tophi. Body urate pool. The total body urate pool is the net result between urate production and excretion. Production is influenced by dietary intake of purines and the rates of de novo purines from non-purine precursors. Nucleic acid turnover and salvage by the phosphoribosyl transferase activities. The formed urate is normally excreted by urinary and intestinal routes. When hyperuricemia exists, urate can precipitate and deposit in tissues as tophi. Nearly all of the uric acid in plasma is present as monosodium urate. At the pH of plasma, that is 7, urate is relatively insoluble. At concentrations greater than 6.8 milligrams per deciliter, the plasma is saturated. As a result, urate crystals may form and precipitate in the tissues. In acidic urine, uric acid is the predominant species and uric acid crystals may form. Now the diseases associated with defects in purine metabolism. Hyperuricemia, gout, Lesch-Nyhan syndrome, kidney stones, severe combined immunodeficiency syndrome, also known as KIDS. Now, renal handling of uric acid. It is important to understand the renal handling of uric acid. It is very complex and involves 4 steps. Uric acid is freely filtered at the glomerulus. At the level of proximal tubule, about 98 to 100% is reabsorbed. This is again re-excreted from the distal portion of the proximal tubule, and in the distal tubule there is further reabsorption. So the net urinary excretion of uric acid is about 6 to 12% of the amount filtered. Now the question. आप अपने अपने पेपर पेंसिल पे इसका सवाल का जवाब लिखो. Which statement best describes xanthine? It is a direct precursor of guanine. It covalently binds to allopurinol. It is oxidized to form uric acid. It is oxidized to hypoxanthine. It is a substrate rather than a product of enzyme xanthine oxidase. मेरे पास वो नहीं आ रहा है. ठीक है ना, हो गया सबका, ये सबको आता है. See, it is oxidized to form uric acid. Now back to the pathway. Here you can see hypoxanthine and xanthine. Hypoxanthine is converted into xanthine and xanthine to uric acid through the action of enzyme. कौन बताएगा? Which enzyme is involved here? Xanthine oxidase. Next question. In gout, there is elevated uric acid concentration in the blood and urine due to a variety of metabolic abnormalities that leads to the overproduction of purine nucleotides. Allopurinol is used in the treatment of gout because this drug and its metabolic product act as inhibitors of A xanthine oxidase, PRPP synthetase, adenyl succinate synthase, hypoxanthine guanine phosphoribosyl transferase and nucleotide. Xanthine oxidase. During metabolism of purine bases, xanthine oxidase catalyzes the conversion of hypoxanthine to xanthine and the conversion of xanthine to uric acid. Allopurinol is a structural analog of hypoxanthine, and it can bind to xanthine oxidase and be converted to alloxanthine, the metabolite responsible for most of the inhibitory effects of administration of allopurinol. The solubility of xanthine and hypoxanthine is higher than the solubility of uric acid, and the renal clearance is 10 times. Next question. 60 years old male presents with severe pain in his left big toe. Joint is swollen, tender to touch, and red. Aspiration reveals fine needle-shaped yellow birefringent. Exactly. Allopurinol. The diagnosis in this case is gout from uric acid deposition in the joint space. Allopurinol is a prophylactic agent and is given to prevent attacks of gout. And it acts by inhibiting xanthine oxidase and prevents further breakdown of purines. All other options are the treatments useful for acute gout. Colchicine is also effective for acute gout. The next question. A 55 years old man has a painful swollen left knee. The symptoms began 2 days earlier. There is no history of trauma. Joint aspirate. Shows pus cells negatively birefringent crystals. No organisms are seen. What is the most likely diagnosis? Exactly. The diagnosis is gout. Gout में बेशक small joints mostly involved होते हैं, लेकिन कभी-कभी larger joints भी involved होते हैं, especially जब ये point है कि negatively birefringent crystals हैं, वो सिर्फ gout में होते हैं. Next question. Which of the following is not associated with hyperuricemia? इसको गौर से सुने और मुझे बताएं. हाँ जी, जवाब बताएं. शहनाज आप बताओ. क्या? Justify your answer. Exactly. शहनाज कह कह रही हैं कि PRPP जो है सबस्ट्रेट है यूरिक एसिड की फॉर्मेशन में, इसलिए इसकी डेफिशिएंसी जो है इट इज नॉट एसोसिएटेड विद हाइपरयूरिसीमिया। बाकी सारी जो कंडीशंस है उनमें सब में हाइपरयूरिसीमिया होता है। HGPRT डेफिशिएंसी में हाइपरयूरिसीमिया होता है। कीटोजेनिक डाइट भी हेमोलिटिक एनीमियाज में सेल ब्रेकडाउन ज्यादा होता है, इसलिए हाइपरयूरिसीमिया होता है। सोराइसिस में सेलुलर टर्नओवर तेज होता है, इसलिए। Next question. A 60 years old man has severe pain at the base of his left big toe. The first metatarsophalangeal joint of his left foot is tender, markedly inflamed and erythematous. Lab studies show a serum uric acid level of 10.4. Light microscopy of synovial aspirate shows the presence of monosodium urate crystals. The most appropriate treatment for this patient's pain is कौन से कोई जवाब आया? उधर के जवाब नजर आ रहे हैं, उधर से हैं। मैंने फुल स्क्रीन किया हुआ है। आप लोग अपने अपने जवाब लिखें, बोले नहीं और शोर नहीं करें। थोड़ा सा टाइम और ले लें, सोच लें सब। हाँ जी फाफे, आपका क्या जवाब है? एग्जैक्टली। बहुत से लोग एस्पिरिन कह रहे थे, एस्पिरिन इसलिए नहीं कि वो हम आगे डिस्कस करेंगे कि एस्पिरिन क्यों नहीं, उसका नुकसान होगा। ये आगे मैं आपको एक्सप्लेन करती हूँ। एस्पिरिन जो है वो लो डोजेस में ज्यादा करेगी uric acid का level, इसलिए colchicine is a better treatment. An inflammatory reaction that is in full swing can be worsened by change in serum urate concentration. Urate lowering drugs should not therefore be initiated during an acute attack of gout. वैसे भी पेशेंट जब आपके पास आता है तो वो अपनी पेन की वजह से आता है, पेन इन्फ्लेमेशन की वजह से, उस वक्त उसको ट्रीट करना होता है। तो इन्फ्लेमेटरी रिएक्शन का पहले इलाज करना होता है। colchicine is a very good option for that. Now we come to the primary hyperuricemia and its causes. Uric acid undersecretion is seen in about 80 to 90% of people, in which no other cause for their high uric acid can be found. Then urate overproduction is seen in 10 to 20% of people, which may be because of increase in substrate levels of PPRP, for example, because of obesity, or it may be idiopathic. Increased nucleic acid turnover, for example, tumors, especially during treatment. Then infection, chronic hemolytic anemia, psoriasis. Then specific heritable enzyme defects, for example, AGPRT or G6PD deficiency, PPRP synthetase overactivity. Secondary hyperuricemia with urate overproduction is seen in myeloproliferative diseases, lymphoproliferative diseases, hemolytic anemias, polycythemia vera, other malignancies, psoriasis, and glycogen storage disease. Secondary hyperuricemia with uric acid undersecretion, seen in renal insufficiency, polycystic kidney disease, lead toxicity, drugs like diuretics, salicylates, pyrazinamide, ethambutol, cyclosporine, and didanosine. मरियम, आप ये देखना कि अगर कोई मैसेज आता है, कोई आवाज वगैरह। Next question. All statements about uric acid stones are correct except. Write down your answer. Right, are a result of hyperuricemia. इसकी justification ये है, in most children with uric acid calculi, we do not see hyperuricemia. Then elevated serum uric acid levels are frequently due to dehydration and excessive urine intake. Consistently low urine pH is a risk factor for stone formation. As the urine pH level increases above 5.8, uric acid forms the more soluble uretine. It may be faintly visible on radiographs due to some amount of calcium, and sometimes these stones are so dense that they become visible. इसके बारे में पहले भी काफी लोगों को शक रहा है, लेकिन ये काफी हमने डिस्कस भी किया है, रेडियोलॉजिस्ट से भी मशवरा कर लिया है. It can be seen on radiographs, not always, but in many cases, especially when there is calcium present or when the stones are dense. Next question. A 60-year-old hypertensive man taking benflumethiazide and amlodipine was commenced on allopurinol after 8 degrees. Pulse was 90 beats per minute. Blood pressure was 140 by 90. Systemic examination was normal. Hemoglobin 12.5, WBC is 15,000, neutrophils is 2%, eosinophils 16%, lymphocytes 22%, urea 15 millimoles, creatinine 300 micromoles, ALT 328, ALP 600, bilirubin 65. What is your diagnosis? ऑप्शन नहीं है इसमें, आपने डायग्नोसिस बतानी है. व्हाट इज योर डायग्नोसिस? मेरा अटक गया. Allopurinol hypersensitivity syndrome. Allopurinol hypersensitivity is seen in about 2% of patients who develop 2% of patients develop a rash, but about 0.4% of patients, those who are on thiazides, they may develop this hypersensitivity syndrome, which is characterized by skin reactions, fever, eosinophilia, multi-organ involvement, and a mortality of up to 25%. Next question. With gout and pseudo-gout, joint inflammation is caused by crystals that form in the synovial fluid. In pseudo-gout, these crystals are nitrate, uric acid, purine. Exactly. ये तो सबको आता है, सारे बहुत लाइक है. असल में हमारे पास DLP के हाफिज मौजूद है. Next question. Effect of thiazide diuretics on uric acid. Increased uric acid excretion, decreased uric acid reabsorption, increased uric acid reabsorption, increased uric acid excretion, and no effect. Decreased uric acid excretion. Diuretics reduce uric acid excretion by both directly and indirectly decreasing uric acid excretion and increasing uric acid reabsorption. Multiple choice questions में हमेशा ये होता है कि एक से ज्यादा ठीक हो सकती हैं, but you have to choose the best option. तो इसमें reabsorption भी increase होती है, लेकिन basic जो mechanism है वो excretion कहा है कि इसका डिक्रीज होने का, क्योंकि यूरिक एसिड वैसे ही 98 to 100% एब्जॉर्ब हो जाता है नॉर्मल किडनी में। हमने देखा है कि प्रॉक्सिमल ट्यूब्यूलर लेवल पे 98 to 100% वो रीअब्सॉर्ब हो जाता है, फिर वो स्क्रीट होता है। तो यहाँ पर recent studies have shown that thiazides compete for the same excretory process by which uric acid is excreted into the proximal tubule, thus reducing the clearance of uric acid and raise the levels of uric acid in the blood. Human organic ion transporter 4, located at the apical membrane of proximal tubule, is also responsible for the facilitation of hydrochlorothiazide associated hyperuricemia. Question 11. Which of the following conditions is associated with most pronounced hypouricemia? मेरे सवाल बहुत आसान है, सबको आते हैं। Hereditary xanthine-urea is caused by a defect of xanthine oxidase and is inherited with an autosomal recessive manner, characterized by decrease of urate and increase of xanthine and hypoxanthine in the blood and urine. May start at any age. Approximately 50% of the patients with classical hereditary xanthine-urea present with symptoms of urinary tract infection, hematuria, renal colic, acute renal failure, crystalluria, or urolithiasis. Diagnosis is based on estimation of uric acid in blood and urine, and there is no curative treatment, but low purine diet and high fluid intake is recommended. Alkalinization is of no value as the solubility of xanthine is not affected by urinary pH. Sometimes pyelolithotomy is necessary. Overall prognosis is favorable. Question 12. Which of the following conditions is associated with hypouricemia? Von Gurkey's disease, adenosine deaminase deficiency, overactivity of PRPP, synthetase, overactivity of amylotransferase, Leschnehan syndrome. बीबी कौन है बीबी? इस वाले सवाल का जवाब है ए. Von Gurkey's disease is associated with hyperuricemia, not with hypouricemia. थोड़ी देर और इंतजार कर लें या जाने आगे चलें? ठीक, good. Adenosine deaminase deficiency is also called as ADA deficiency or ADA SCID. It is a variant of SCID, severe combined immunodeficiency syndrome. It is an autosomal recessive metabolic disorder that causes immunodeficiency, and it occurs in fewer than 1 in 100,000 live births worldwide. Accounts for about 15% of all cases of SCID. In this pathway, you can see this ADA enzyme is responsible for the conversion of adenosine into inosine, which further goes the pathway and is excreted as uric acid. When there is deficiency of ADA, this adenosine starts building up. There is this buildup of adenosine, hypouricemia, and this buildup of adenosine in cells results in early destruction of the cells, early death of cells, especially lymphocytes. deaminase catalyzes the conversion of, as I have told you, adenosine to inosine, and its deficiency results in accumulation of AD is essential for the metabolic function of a variety of blood cells, but especially the T cells. Its absence leads to accumulation of toxic metabolic byproducts within lymphocytes that cause cells to die. Babies with this type of skin have the lowest total lymphocyte counts. T, B, and natural killer lymphocytes counts all are very low. Next question. Hypoxanthine analog allopurinol, which effectively treats gout, has no effect on the severe neurological symptoms of flashing on patients because it does not decrease de novo purine synthesis, decrease de novo pyrimidine biosynthesis, decrease urate synthesis, increase PRPP levels, inhibit xanthine oxidase. अपने अपने जवाब लिख लें सारे. एक मिनट. मरियम एक मिनट रुक लो. कौन बताएगा? चल आसम बताओ. मेरा तो पहला क्रिएटिविटी लेवल ज्यादा करता है, इसलिए जीपीआरटी को जो है ना इसकी डेफिशिएंसी से हो रहा है, जीपीआरटी का सेलेक्ट से एडिनी वाला पढ़ाते हैं. मेरा वो कम करेगा. इसका जवाब है कौन सी निशान की? Because it does not, आप इसमें not पे गौर करें, it does not decrease de novo purine synthesis. It does not, अब ये तो नहीं बनेगा, डी ऑप्शन नहीं बन सकती इस तरह. सवाल को व्हाट्सएप पर टाइप करें, तो इसमें लिखा हुआ है does not, ठीक है. It does, इसके ऑप्शन ए de novo purine. इसका मैं पहले एक दफा आपको बता देती हूँ थोड़ा सा, उसके बाद मैं आपको पाथवे पे दिखाती हूँ. It inhibits xanthine oxidase, which catalyzes the oxidation of hypoxanthine to xanthine and then to uric acid. ये सबको पता है allopurinol का एक एक्शन ये है. It also inhibits the purine synthesis by inhibiting the rate-limiting enzyme PRPP aminotransferase. As it is a purine analog, allopurinol must be converted to its respective nucleotide by AGPRT to inhibit this enzyme. ये पाथवे में आप देखें, यहाँ पर ये जो जितने भी हमारे प्यूरिन न्यूक्लियोटाइड्स हैं, ये प्यूरिन बेसिस में जब कन्वर्ट हो रहे हैं, अब जब यहाँ पे तो एक्ट कर रही है आपकी मेडिसिन एलोप्यूरिनॉल, और इस लेवल पे यूरिक एसिड नहीं बन रहा, लेकिन एक नेगेटिव फीडबैक भी होता है. ये वाले ये एजीपीआरटी के थ्रू जो साल्वेज पाथवे है, जब यहाँ पर ये प्यूरिन न्यूक्लियोटाइड्स रीस्ट्रक्चर होते हैं, तो इनका एक नेगेटिव फीडबैक इफेक्ट होता है पीआरपीपी अमाइलोट्रांसफरेज पर, और वो फिर इनहिबिट करता है आगे इसकी सारे प्रोसेस को. लेकिन जब यहाँ पर एजीपीआरटी की टोटल डेफिशिएंसी होती है, तो ये फीडबैक खत्म हो जाता है. इसलिए मुसलसल प्यूरिन्स बनते रहते हैं, और इन पेशेंट्स में so it needs an intact AGPRT, as in Lesch-Nyhan syndrome. There is complete deficiency of this enzyme, so it cannot inhibit purine synthesis, which continues unchecked. The gouty arthritis caused by urate crystal formation is relieved in these patients, but their neurological symptoms, mental deficiency, self-mutilation, and compulsive chewing of fingers and lips, these are not relieved. And question 14. 55 years old man comes to the emergency with a throbbing ache in his great toe. On examination, he is noted. नहीं, वो मेरे पास मुझे क्या जवाब है? अच्छा जी, और हाँ जी, इधर से कोई बताए, सामान बताओ। ठीक, ये कौन बताएगा? एस्प्रिन। और उसका मैकेनिज्म मैकेनिज्म कौन बताएगा? इसमें क्या होता है? सामान तुम बताओ। बायोफिजिक एक्शन कैसे है? इसीलिए इसे एक्यूट गाउट में हम नहीं देते, because at low doses it blocks the tubular filtration, resulting in hyperuricemia. And at high doses, more than 3 grams per day, it acts by inhibiting the reabsorption in the proximal tubule, resulting in uric polyuria. Low doses में uric acid increase करता है एस्पिरिन, इसलिए एस्पिरिन हम लोग जो है उसमें नहीं देते हैं acute attack। मुझे नाम नहीं आता और मुझे आवाज Question 16. Sumo wrestling is a common sport in Japan. A sumo wrestler takes about 5,000 calories per day, not different from our pahalwans. Studies have shown that high incidence of hyperuricemia in these wrestlers. Please answer the following. What two possible causes of hyperuricemia in these wrestlers, and what is the biochemical mechanism of hyperuricemia related to their diet? Very good, Sumbal. बायोकेमिकल मैकेनिज्म क्या है हाइपरयूरिसीमिया का? ये पाथवे जो है इसको समराइज कर देते हैं। जो बायोकेमिकल मैकेनिज्म है, एक्सेसिव डाइटरी कार्बोहाइड्रेट्स रिजल्टिंग इन हाँ से शोर नहीं करें आप, increased level of acetyl CoA, which is very difficult to clear through the TCA cycle. So it is converted in the formation of fatty acid, and NADPH is required for this purpose. NADPH has an inhibitory effect on the pentose phosphate pathway. When this inhibition is removed, there is increased production of fatty acid and increased production of pentose phosphate pathway. Through pentose phosphate pathway, this increased production of PTRP, which is a substrate for the formation of uric acid. Thus, these pahalwans have high uric acid. And secondly, their infrequent diets result in more ketone formation, and ketones interfere with tubular excretion of urates, leading to hyperuricemia. Then 17. A 45-year-old male is known patient of chronic kidney disease. He has following biochemical findings. His urea is 27.8 millimoles, creatinine is 74 micromoles, uric acid 12. Why is his uric acid not very high in spite of the fact that kidneys are an important source of uric acid excretion? Exactly. GI excretion is increased from 25% to 65% in case of chronic kidney disease. And secondly, because of the kidney disease, there is decreased reabsorption of urate in the tubules. Question 18. It is said that only man and a few mammals can develop gout. What is the biochemical background of this statement? मेरे सामने तो ना सो. Exactly, Sawahal. बाकियों के पास uric acid है, which converts it into allantoin, which is freely soluble and can be excreted easily. ठीक है. So we are at disadvantage because of the absence of uric acid enzyme. And secondly, urinary absorption is seen in only in higher mammals. हमारे और बाकी चंद एक mammals हैं जिनमें ये reabsorption हो जाती है जिसकी वजह से मसला होता है. Then the last question is, a 54 years old male has moderately severe pain in his right knee with swelling and redness. He has following lab findings: urea 6.9 moles, creatinine 91 micromoles, uric acid 288, fluid analysis, rectangular shape, positive or polarized microscopy. What is the most probable diagnosis? और किसी का? Pseudo gout majority का pseudo gout. Points that favor pseudo gout crystals with positive. आज शेयर हो जाए. Points that favor pseudo gout: rectangular crystals with positive birefringence on polarized microscopy. Calcium pyrophosphate dihydrate crystals, large knee joint involvement, moderate pain, swollen joint, serum uric acid usually normal, and age greater than 50 years. All these features are suggestive of pseudo gout. Now, any questions? कोई सवाल किसी का?
Excellent, madam. Excellent.
आपकी तरफ आवाज ठीक आती है क्योंकि मुझे यहाँ पे ऐसा लग रहा था कि मेरी आवाज कहीं नहीं जा रही. Thank you, Sambal.
Questions time है, madam. Questions.
मुझे आवाज नहीं आ रही. अगर कोई क्वेश्चन है तो प्लीज सामने बोल भी सकती हो. अच्छा, साथ बैठे हैं.
Kindly, any question from any side?
सर, बच्चों ने सर की डीएलपी से सब कुछ याद कर रखा है. सारे डीएलपी के हाफिज हैं हमारे पास.
इसका तो मिलता है.